আসসালামু আলাইকুম স্যার, আমরা লাইভে চলে এসেছি, আপনি শুরু করতে পারেন।
ওয়ালাইকুম আসসালাম, থ্যাংক ইউ কল্পনা। Assalamu alaikum and welcome you all today's regular dermatological class. So আজকে আমরা খুব ইম্পর্টেন্ট একটি টপিক নিয়ে আলোচনা করব। ডার্মাটোলজির খুব ইম্পর্টেন্ট একটি ডিজিজ লাইকেন প্ল্যানাস। আমরা সাধারণত আমাদের ডেইলি প্র্যাকটিসে খুব কমনলি এই পেশেন্টটা পেয়ে থাকি। ডার্মাটোলজির যে কয়েকটা কমন ডিজিজ আছে তার মধ্যে লাইকেন প্ল্যানাস অন্যতম, এবং আন্ডার গ্রাজুয়েট স্টুডেন্টদের জন্য এটা খুব গুরুত্বপূর্ণ। আশা করছি আজকে আমাদের এই আলোচনা থেকে নিশ্চয়ই তারা উপকৃত হবেন। সো আমরা শুরু করি। আমি ডাক্তার মাহবুব শাহিন, সিনিয়র কনসালটেন্ট অরোরা স্কিন অ্যান্ড হেয়ার রিসার্চ ইনস্টিটিউট। আগামী 30 মিনিট আশা করছি আমাদের ভালো সময় কাটবে। আমরা লাইকেন প্ল্যানাস নিয়ে একটু প্র্যাকটিক্যাল ওরিয়েন্টেড ডিসকাশনে যাবো। সো প্রথমে যদি একটু জানার চেষ্টা করি লাইকেন প্ল্যানাসটা কি। ইটস এ কমন immune mediated papillosquamous inflammatory skin disease. So these are the important points. Again, I mention is a common immune mediated papillosquamous inflammatory skin disease, and characteristic features are flat topped skin colored or violaceous and pruritic papillar eruption. So these are the characteristic features, and the prevalence is almost 1% throughout the worldwide populations. So there are several clinical types of lichen planus that actually share the similar features of histopathology. Epidemiology, as I have mentioned earlier, it's a very common dermatological condition. Near about 1% of the whole population throughout the world affected by lichen planus, and more than 2/3 of the lichen planus patients are middle-aged adult patients, in fact, but children are also affected. However, lichen planus can occur at any age, and 50% of the lichen planus patients have oral mucosal involvement, and it is more common in women than men. Approximately 10% patients have nail involvement, and hair involvement is rare, it's not common. So accordingly, all sorts of dermatological disease have some sorts of involvement, either skin, hair, nail, mucous membrane, or all. So Etiopathogenesis, as I have mentioned earlier, it's an immune mediated. So this is a T cell that actually plays an important role, autoimmune disorder, which is inflammatory cells and attacks. In fact, this T cell attacks an unknown protein within the skin and mucous membrane keratinocyte. As you know, keratinocyte is a very important cell of skin and mucous membrane. So these T cells actually affects this unknown protein of keratinocytes and finally produce the disease process. And the factors that contributes for the development of lichen planus, it's a genetic predispositions, physical and emotional stress, injury that actually called coagularization, and some sort of systemic infections like hepatitis C infections definitely plays an important role for the development of the disease, contact allergies, and some sort of drugs like Goole, quinidine, and other drugs that actually causes lichenoid rash or lichenoid drug eruption. So presentation, this is very important for us. How can we actually diagnose a case of lichen planus clinically, or how a patient of lichen planus in fact present in our chamber? So this is a very classical presentation of lichen planus. If we carefully observe or see this photograph, there are multiple actually অনেকগুলি violaceous color. This is the very important violaceous color, papules and plaques. This is very important, violaceous color, and this is unique. This is the only disease where commonly we find this type of violaceous color, and papules and plaques have flat top surface and commonly affects the dorsal surface of the hands, flexor wrist, and lower legs. So this is the classical presentation of lichen planus. Sometimes patients may present on the dorsal surface with this type of lesion, that is plaque, in a linear pattern. Of lesions that actually called the coagulation, which is a very characteristic features and indicates the disease activity. This is another site of involvement, lower legs, and this is classical or typical papule that has a flat-topped and smooth surface. And this is a coagulation, linear development of the lesion along the site of trauma. This is coagulation. And this is another, this is a very common site, dorsum of the hands. And the picture shows the lesions that is actually plaque, which is dyspigmented. Both hypo and hyperpigmentations is there. And these lesions are actually plaques and commonly affects lower legs. And this is pre-malignant condition. This is called hypertrophic lichen planus, and hypertrophic lichen planus is a pre-malignant condition, and chance of development of small cell carcinoma. Sometimes we found patients are presented with lichen planus with these complications of small cell carcinoma. So another picture, close view of this hypertrophic lichen planus that actually turned into small cell carcinoma, which is actually established the diagnosis by doing biopsies for histopathology. So another present types, clinical types of lichen planus, this photograph shows hyperpigmented, well-defined hyperpigmented patches, and commonly in the sun-exposed area, usually asymptomatic. So it's a classical picture of actinic lichen planus. Lichen planus pigmentosus, it's another clinical variety of lichen planus. Patients may present in this type of lesions. This is hyperpigmented, diffuse hyperpigmentations, which is actually asymptomatic, and most commonly we have found this type of patients actually presented with the face and truncal involvement. This is another patient of lichen planus pigmentosus or ichthyomatosis. Look at the diffuse pigmentation involving the face, neck, and the trunk, upper part of the chest. So it's a mucosal lichen planus involving only the lower lips, and patients sometimes complains there is some sort of burning or pain sensations. And this is the involvement of the buccal mucosa. If you see, so it's a very common site of involvement of lichen planus, and patient may complain pain or burning. And if you examine, you can see this lace-like or net-like pattern distribution. It's a plaque, whitish plaque. So it's a very classical presentation of oral lichen planus. And I have mentioned earlier, the more than 50% patients of lichen planus involving the skin presented with this oral mucosal involvement. So if we found a case of lichen planus, definitely we have to examine. We must examine the oral cavity to find out any sort of oral mucosal involvement. That is very important. So vulvovaginal lichen planus is associated with oral mucosal involvement. Vulvovaginal involvement of this type of lesions, partly erythematous and violaceous, both vulvar and vaginal involvement, along with oral mucosal involvement, and look at the involvement of the skull. So as you know, to complete the examination of a dermatological patient, we must examine all the things like skin, hair, nail, and mucous membrane to confirm the diagnosis. Otherwise, we can miss the diagnosis. So definitely, to examine a patient or to deal a patient of skin disease, any dermatological diseases, definitely we have to examine all these things like skin, hair, nail, and mucous membrane. This is genital lichen planus involving the glands and part of the body of the penis. And patients, most of the cases presented with only these features, but there is no symptoms. Sometimes mild itching or burning may be present. So this is not very common, but sometimes patients may present with this type of lesion, the genital lichen planus in case of male. And this is another classical presentation. If you look, is annular lesions. And if you are not very much familiar to this type of lichen planus, definitely you can misdiagnose is a case of tinea. So it's very important to examine the patient properly. Is annular lichen planus involving the glands, body of the penis as well as the glands. Nail involvement, what I have mentioned earlier, near about 10% or more cases of lichen planus involve the nail, and pterygium is the classical presentation of lichen planus. This is the classical presentation of lichen planus, that is pterygium. This is pterygium. So this is very important findings, and there are some sort of longitudinal ridging and onycholysis in the next photograph. Look at this is a onycholysis. Distal onycholysis, as well as there's many longitudinal ridgings. So these are the very common findings. Sometimes it may confused with common nail disorder like onychomycosis or dermatophytosis. So even may confused with the psoriasis, nail psoriasis. So in that case, we have to examine the patient's skin, hair, and other parts of the body, and finally we can confirm by doing biopsy for histopathological findings. And this is the lichen planus involving the scalp, particularly the hair follicles. So this is called lichen planopilaris. Though it's not common, but it's not rare at all. Sometimes we find this type of patients presented with the hair loss. And if we examine these patients and if we go for the trichoscopy and finally go for the biopsy, definitely we can confirm the diagnosis. And this is very important to confirm the diagnosis. Otherwise, we cannot treat these patients properly. So to treat this type of problems, definitely we have to confirm that diagnosis by doing this trichoscopy and biopsy. So this is another case of lichen planus involving the scalp, that is lichen planopilaris. So trichoscopy is a very important tool for the diagnosis of lichen planopilaris. And this is another case of lichen planopilaris, though it's actually called the frontal fibrosing alopecia, and it's one type of lichen planopilaris as well, involving the frontal area of the scalp and as well as the involves the eyebrows. So it's a classical presentation. So now how can we confirm the diagnosis? So clinically, after taking history and proper examination, we can diagnose provisionally, but to confirm the diagnosis, we must go do the biopsy, and is often recommended to confirm the diagnosis as well as to make the diagnosis and look for any cancer. As I have mentioned earlier, there are some variety of lichen planus, like oral lichen planus, that is ulcerative variety, and hypertrophic lichen planus. This type of lichen planus have a tremendous chance of development of malignancies like squamous cell carcinoma. So to confirm or to exclude any sort of malignant changes, definitely we have to go for the biopsies to find out the histopathological changes. So histopathological signs are of the lichenoid tissue reactions affecting the epidermis, as you know. On the right side photograph, this is a classical picture. This is hyperkeratosis, and this is hypergranulosis, and this is liquefaction of the basal cell. Here is the basal cell degeneration, and there is a band-like infiltration. I can show you the classical band-like infiltration. This is the classical band-like infiltration and liquefaction of degeneration of the basal cell. So these are the classical picture, that is hyperkeratosis. This is hyperkeratosis, hypergranulosis. This is hypergranulosis, and there is a liquefaction degeneration, and this is the band-like infiltration of the lymphocytes. So melanin incontinence are beneath the epidermis. So these are the classical picture under microscope that can actually confirm the diagnosis. And this is another diagnostic tool to see whether it is lichen planus or not. That is DIF, direct immunofluorescence. And direct immunofluorescence staining may reveal deposition of the immunoglobulin at the base of the epidermis. So also helps to confirm the diagnosis. So after confirmation, so definitely we have to plan to manage these cases, and it's very important for the management to confirm the diagnosis. So after confirmation, we can plan. As you know, treatment plans are always, we divide to the general measures, topical, systemic measures, sometimes surgical measures. So according to need. So in that case, the same protocol we have to follow. The first of all, topical preparations. And before that, counseling is very important as because it's a chronic disease. As you know, it's autoimmune disease, though the prognosis is very good, but it will take a long time, even 2 or 3 years in most of the cases, particularly the classical lichen planus involving only the skin. So this prognosis is very good. I will definitely discuss later on regarding the prognosis. So counseling is very important. So we have to clear up our patients. That's a chronic problem. You have to continue this treatment for a longer period of time, and definitely it will cure. So treatment, though it's not always necessary, but the symptomatic treatment is very important. Pruritus is a very common feature, so antihistamines definitely you will provide. Along with topical preparations, potent topical corticosteroids, tacrolimus, as you know, it's calcineurin, and topical retinoids. These are the common topical preparations. In fact, in case of acute conditions or severe itching, extensive lesions, we can start with this potent topical corticosteroid for 10 to 14 days, maximum 2 weeks. So after that, a patient definitely will improve, at least the acute condition will subside, and then we'll go to maintain the improvement with this preparation, that is tacrolimus, calcineurin inhibitors. That is a very safe drug. Even retinoids can be used as a maintenance treatment, but definitely you should not continue this potent steroid for more than 2 to 3 weeks. That will actually causes so many adverse effects, as all of you know, that the adverse effect of topical potent corticosteroids. So international injections are actually the treatment of choice in case of hypertrophic lichen planus. So it's, as you know, 40 milligram per ml triamcinolone acetonide. In hypertrophic lichen planus, we actually give the full strength of 40 milligram. Sometimes we give the half strength. Actually, it depends on the type of the lesion, size of the lesions, and its character of the lesions. So inhalation injection, in particularly hypertrophic lichen planus, as well as oral lichen planus, you can also give these treatment modalities. Systemic treatments, actually in severe form, acute form, definitely steroid is the treatment, that is prednisolone we used initial 2 to 4 weeks. In fact, that actually helps to control acute or severe conditions, and particularly in severe widespread conditions. So after that, we can maintain with this sort of drugs, that is retinoids, acetretin, hydroxychloroquine, methotrexate, anyone we can choose according to the patient's response. First of all, definitely acetylcholine, then we can use hydroxychloroquine or methotrexate or azathioprine. So as you know, this drug selection is important considering the patient's parameters, comorbid conditions, physical status, and all other things. So these are the options, in fact. So we can use these drugs according to the severity. In acute and severe and extensive involvement, these are the drug of choice. Other treatment options, as you know, phototherapy is also a very important tool for the management of dermatological condition, and definitely in lichen planus, particularly in generalized lichen planus, we can use this phototherapy, either PUB or narrow-band ultraviolet B. Anecdotal success is reported from the long course of oral antibiotics and oral antifungal drugs in case of lichen planus, particularly oral lichen planus. And lichen planopilaris that actually involves hair follicles reported to improve with pioglitazone. That is, as you know, insulin sensitizer. So lichen planus and comorbidities is very important, and study shows there is clear association of lichen planus with dyslipidemia and diabetes mellitus. As you know, these are the associate conditions or comorbid conditions actually found in psoriasis as well. So screening for dyslipidemia and diabetes mellitus in all patients of lichen planus definitely helps in early detection, initiation of the treatment, and prevent long-term comorbidities. So it's very important. So skin problems are not only confined with the skin, but definitely you have to see the internal organs through the skin. So you have to think all these important key points. So lichen planus and comorbid conditions to identify this comorbid condition, you have to search for this whether any dyslipidemia or diabetes mellitus according to the need of the patients. So complications, what I have mentioned earlier, that squamous cell carcinoma, particularly oral lichen planus and hypertrophic lichen planus, the chance of development of squamous cell carcinoma is common, and vulval cancer, penile cancer is also the complications may develop and should be suspected if there is any enlargement of the lymph nodes on the affected area, particularly the neck glands in case of oral lichen planus, or definitely vulva or penile, that's inguinal lymph nodes. So this is very important, and cancer is more common in smokers. If lichen planus patients have history of smoking or history of cancer in the mucosal sites, previous history. So that's very important, and cancer from other forms of lichen planus is usually rare. So mucosal and hypertrophic lichen planus are the main predisposing factors by source. This is a pre-malignant condition for the development of the malignancies. So prognosis, cutaneous lichen planus, that is classical lichen planus that involves skin only, tends to clear within a couple of years in most of the patients. That is very, very important. This information you have to know, and then you can counsel your patients, and patients always wants to know about whether this disease is curable or not. In case of psoriasis or other disease, we actually cannot tell our patients it's a curable disease. As you know, all these are controllable disease, but lichen planus definitely have a better prognosis, and within 2 to 3 years, spontaneously it's clear up. So it's a very important message, as well as a very positive message to our patient. And mucosal lichen planus is more likely to persist for a decade or longer. That's the important message, that oral or genital mucosa or mucosal involvement of lichen planus usually not cleared up as soon as the skin lichen planus, cutaneous lichen planus. So in that case, we have to be careful and follow up these patients, counsel these patients properly, and definitely follow up is important whether there is development of malignancies or not. And spontaneous recovery is unpredictable, and lichen planus may recur at a later date. So recurrence may be occur as because it's an autoimmune disease. And scarring is permanent, including balding of the skull. That is in lichen planopilaris. If the lichen planus involve the scalp, that is hair follicles, and if we do not identify this disease early and treat early properly, then definitely there is a chance of development of scarring and leads to scarring alopecia. And lichenoid drug eruptions are, as you know, I have mentioned earlier, some sort of drugs that actually causes lichenoid drug eruptions that actually cleared up slowly when responsible medication is withdrawn. So this is another important message. So considering the prognosis overall, definitely Lichen planus has a very good prognosis, and definitely we have to counsel our patients properly. So if we recapitulate again as a whole, the Lichen planus, it's a chronic inflammatory skin disease that actually involves any age, but most commonly involves the adults 30 to 60 years. Children may also affected, and definitely women are more commonly affected than men, particularly in case of oral lichen planus. And patients are presented actually in different ways. I have mentioned the patient may present with only cutaneous involvement, that is flat top violaceous papular lesions that involves the typical site, dorsum of the hands, lower extremities, flexural surface of the forearms, involvement of the nail, that is sterism is a classical characteristic features of the nail involvement, and oral mucosa, particularly buccal mucosa commonly involves, and definitely rarely hair involvement, that is lichen planopilaris. So these are the classical presentation, and definitely we can confirm this diagnosis by doing biopsies for histopathology as well as DIF. And after confirmation, we can go for the treatment, and treatment includes the counseling to the patients properly, topical preparations, as I have mentioned, that is topical corticosteroids, topical tacrolimus, and definitely topical retinoids we also use, and systemic drugs, particularly intralesional steroid corticosteroid injection also plays an important role, particularly in case of oral lichen planus or hypertrophic lichen planus, and definitely in case of nail lichen planus, we also sometimes give intralesional corticosteroid injections, and systemic drugs like systemic steroids, methotrexate, acitretin, and some other drugs we actually use in case of severe, acute, and extensive cases that actually helps to control the disease. Definitely complications, small cell carcinoma develops from the oral lichen planus or hypertrophic lichen planus, and comorbid conditions of lichen planus is dyslipidemia and diabetes mellitus. Even hepatitis C, we have to search screen for this, as because sometimes hepatitis C acts as a predisposing factors may be associated with lichen planus, and definitely prognosis is good comparing the psoriasis or other chronic diseases. So that's all about the lichen planus. I think thank you everybody. That will help you, the undergrad as well as postgrad students for their exam. Even in their clinical practice, you can, I think, diagnose a case of lichen planus clinically easily, and definitely you can treat these patients accordingly. For at least the primary treatment you can give these patients. So that's all about our today's lectures. Hopefully you will enjoy these lectures, and see you again with definitely another important topics. If you have any demand, or if you have any topic you want to know about this, definitely let me know. থ্যাংক ইউ, সবাইকে অসংখ্য ধন্যবাদ। আজকে আমরা শেষ করছি। নিশ্চয়ই আমরা আগামী ক্লাসে আরো গুরুত্বপূর্ণ টপিক নিয়ে আমরা আসবো। ততক্ষণ সবাই ভালো থাকুন, সুস্থ থাকুন। আসসালামু আলাইকুম।